Hi, everyone. My name is Aaliyah Lewis. I'm part of the Master's Forensic Science program, part of the 2020 cohort. And today I'm going to be talking to you about drug metabolism. So, just to review the order of kind of drug metabolism in general, you have absorption, distribution, metabolism, and then excretion. And these four parts of drug metabolism can be affected by a number of things. So, sex, body weight, health status, age, race, genetics, drug interactions, and how recently the person ate all affects to some degree one or more parts of drug metabolism. So, assuming we're looking at an orally administered drug, the drug is going to enter the mouth, go down the esophagus, and into the stomach. In the stomach, the high pH is going to make the drug unionized, increase its ability to enter the bloodstream. And then from the stomach, the drug is going to enter the small intestine, where about 70% of all absorption occurs. And then once the drug is in the bloodstream, distribution begins, it goes around the body and eventually enters the liver, and that is the main site of metabolism. So, metabolism is the process that breaks down a drug or chemical so it can be excreted by the body. So, that's the overall goal of metabolism is to excrete that drug or chemical. And through this process, that the drug can either be made active or inactive. And in most cases, it's going to be kind of a combination of both. Some factors that affect metabolism are genetics, age, drug interactions, and health status. From that list before that covered a bunch of things that affected all parts of drug metabolism. These four specifically tend to affect metabolism. Genetics, polymorphisms, or changes in the genes majorly responsible for drug breakdown. We're going to talk about genetics and polymorphisms in these genes a little bit later when we talk about pharmacogenetics, but genetics are a pretty major role in affecting metabolism. Age, elderly people and children tend to have reduced metabolism or underdeveloped organs. So, of course, that first part, reduced metabolism, kind of correlates more with elderly people. As people age, their body systems kind of start to slow down, and then children tend to have underdeveloped organs. That's why when you're buying children's medication, you'll see children's Motrin, children's Tylenol, and it's specifically for kids because it's either in a way that's easier for them to take, or it's always pretty much going to be a lower dose. There's very few drugs that you would be giving a child and an adult the same dosage. And then drug interactions can lead to decreased metabolism through enzyme inhibition or increased drug metabolism by enzyme induction. That's why whenever you go on a new medication, they always tell you talk to your pharmacist. Sometimes a pharmacist will like pull you aside and be like, hey, just so you know, if you're still taking drug A, this new drug, drug B, can interfere with it. They'll tell you what to expect. Drug interactions are a big thing, and most providers should be aware of them, but kind of always an important thing to think about. And then for a health status, various health conditions such as circulatory problems, liver problems can impact metabolism. Specifically, again, other health conditions such as renal disorders can affect excretion, stuff like that. Drug metabolism usually occurs in the liver and can be broken down into two phases. In phase one, the parent drug or prodrug is converted to a more polar, more water-soluble active metabolite through the addition of polar groups. And then in phase two, it's a continued breakdown of the drug to prepare for excretion. Phase one metabolism converts the like I just said, chemically active prodrug into an active metabolite. This phase involves oxidation, reduction, and hydrolysis reactions to increase the water solubility of the drug through the addition of polar functional groups, such as OH groups, SH groups, and NH2 groups. This is usually done by the family of P450 enzymes. Again, we're going to talk about that a little bit later. After the addition of these polar groups, the metabolite re-enters the circulatory system, where some of the metabolite will go into their target cells, while some will just be cycled back around through the body and back up into the liver. So once a drug is done with its phase one metabolism, it'll enter phase two. So once metabolite has served its purpose, phase two metabolism will begin. And during this stage of metabolism, the drug will be affected by glucuronidation, acetylation, and sulfaction reactions. And these are conjugate reactions that increase water solubility even more to prepare the metabolite for excretion because, as you know, especially through the renal system, most of what's excreted is urine. So you need the drug to be very water soluble. So it'll pass through into the bladder and into the urinary system. So this is just kind of an overall chart of what we just talked about. You can see phase one on the left, phase two on the right. You can see there's kind of two pathways. So there's that oxidation pathway, and then there's the hydrolysis and the reduction pathway. And then you can see from oxidation reactions, they go through the conjugation, and the hydrolysis reactions will usually go through either sulfaction, acetylation, or glucuronidation. And then you'll see also that where it's R, those are more lipophilic, they go towards more hydrophilic. And like I said, the goal is to just be as hydrophilic as possible, as water soluble as possible. Here we have a really great example of drug metabolism. So you can see here that we're starting with the parent drug codeine and the parent drug heroin. And from there, we ultimately end up at morphine from both of them, but there's a little stop along the way for heroin. There's that active metabolite, 6-acetylmorphine or 6-AM. And that's really the only for sure indicator that someone took heroin, because if you get someone's tox screen back and they have high levels of morphine, or they have just any level of morphine in their system, some people may just be like, see, morphine is a metabolite of heroin, so they must have taken heroin. But that's definitely not always the case, because there's multiple pathways to get to morphine. So one possible thing is morphine is a drug in itself. Maybe they just took morphine. Maybe they took codeine, and what you're seeing is a metabolite of morphine, is the metabolite morphine. Or you could get a tox screen that is positive for hydrocodone, hydromorphone, and morphine, and you could be like, wow, like this person took a lot of different drugs, but that's not always the case. So knowing, especially with stuff like this with opioids, it's really important to kind of be able to backtrack some metabolism and see, is there another reason why that tox screen is what it is? And that's something that needs to be taken into consideration whenever you're doing any type of analysis. But you can see here too that there are some arrows that I put, it just kind of looks like some letters and numbers next to, but those are actually enzymes that are coding for the metabolism. So if you remember before, I briefly mentioned the CYP450 enzymes, and you can see here there's CYP2D6, CYP3A4, and CYP2C8. And those are all parts of first pass metabolism. So those are all oxidation reactions. And this is what I meant before when I was saying that sometimes it takes multiple rounds of first pass metabolism. And you may not even make it into second, necessarily phase two metabolism. So on the other end, you can see here these genes that are UGT2B7. That is part of phase two metabolism, and those hydromorphone 3 glucuronide and morphine glucuronide are very hydrophilic metabolites, and that's what's excreted. So you usually won't see, at least nothing that I've seen, will you really get a tox screen that's like, oh, they have normorphine in their system. But it's a possibility. And again, that's just something it's good to know, that normorphine is a metabolite of morphine. So then just to round out, after metabolism is done, we have excretion. Once this is usually how these drugs leave the body. They're very water soluble, and they're just excreted out in the urine. They can also be excreted out through sweat. So that's pretty much metabolism, the metabolism part of drug metabolism. So next we have pharmacogenetics to talk about, which is, like I said before, a kind of important part of metabolism that really has to do with genetics and changes in the genome that affects metabolism. So, what is pharmacogenetics? It is the study of the effect of a single gene factor on the response of individuals or population subgroups to certain drugs. The role in pharmacogenetics is something that should be taken into consideration for forensic toxicology testing, such as during therapeutic drug monitoring programs, human performance testing, and postmortem toxicology. Um, so I just wanted to review a couple of keywords before we move on. So a cytochrome is an iron-containing protein that form the inner part of the mitochondrial membrane, and they function as electron carriers in oxidative phosphorylation. Pretty much, they're just part of the oxidation part of metabolism. A genotype is a person's genetic makeup. A phenotype is their observable expression of the genotype. A polymorphism is a variation in a person's genetic code that's different from what we would assume as like the wild type or the standard code. Usually it's presented as a single base pair, but it can be larger. And then a variant is just an abnormality within the genetic code. So CYP450, or the cytochrome P450, is a family of enzymes responsible for a huge amount of drug metabolism. Single nucleotide polymorphisms, or SNPs, have been shown to have an impact, and the variation of CYP enzymes are broken down into 4 phenotypes, but there are a ton of genotypes. It's a very, very polymorphic gene, and it's a very complicated gene, but they were able to kind of code everything for the genotypes into one of these 4 groups. So first we have poor metabolizers. They normally do not have any functional, or here we go. So you can see here that poor metabolizers have null alleles. They have non-functioning alleles. They will not be able to go through that first phase of metabolism, and it can cause some really detrimental effects. And then we have intermediate metabolizers. So this is assuming that you have some non-working alleles or you have some partially defective alleles. So this is kind of what I was saying, where it gets kind of complicated. It's not like pretty recessive and dominant inheritance where you either get one or you get the other. In this, there's a lot of commingling. There's a mix of genes that work really well, genes that don't work so well. So intermediate metabolizers tend to have more of those genes that don't really work too well. Then you have extensive metabolizers. These are kind of the wild type or the normal. They have 2 functional copies that work perfectly fine. And then ultra rapid metabolizers have more than one gene that is functional. So they have kind of like a surplus of these enzymes. So CYP enzymes are classified into families and subfamilies. For today's purposes, we're mainly going to be looking at the CYP2 family, and then the 2D6 and C19 subfamilies. CYP2D6 is responsible for the biotransformation of xenobiotics, opioids, antipsychotics, and beta blockers. And CYP2C19 has a lot to do with antidepressants and benzos. So I'm going to talk to you about a few case studies where people had genetic polymorphisms in their CYP genes, and kind of what the impact of that was for them. So to start, we're going to talk about morphine. So someone who was an ultra rapid metabolizer of codeine. So remember before that slide where we were seeing that codeine is metabolized into morphine. So this woman was an ultra rapid metabolizer for codeine. They didn't know it. And she was prescribed codeine after she had given birth to her child. And she was breastfeeding the child at the time. And the 13-day-old infant ended up passing away from morphine toxicity. And so the woman was charged with murder, and it was a whole big thing. And what they ended up finding was that she had a polymorphism and was an ultra rapid metabolizer with an extra functional copy of the gene, which increased the metabolism from codeine to morphine. So she had increased levels of morphine in her body, which then filtered through into her breast milk. And this kind of led to a lot of research about ultra rapid metabolizers and morphine specifically. And they found that ultra rapid metabolizers can have up to 50% higher plasma concentrations of morphine compared to regular metabolizers. And then, as we know, your breast milk is a filtrate of the plasma. So that's how the morphine got into the breast milk and sadly poisoned the child. Next, we have tramadol. Tramadol is actually an inactive drug. It's metabolized by CYP2D6 to an active metabolite of O-desmethyltramadol. Um, in this case, a man with renal insufficiency and a CYP2D6 ultra rapid metabolizing genotype developed post-operative respiratory depression due to a tramadol IV. So pretty much similar to what happened with the codeine and the morphine in the last slide, this person was being given IV tramadol and his body was just metabolizing it really quickly. So he had a lot of this active metabolite and it ended up causing respiratory depression. So it was almost like he overdosed. And this kind of brings to light the fact that ultra rapid metabolizers are at a greater risk for opioid related adverse effects and would benefit from lower doses of prodrugs. So in this case, knowing that the man was an ultra rapid metabolizer, they should have given him a substantially less amount of tramadol to begin with. This is just talking about methadone in general. So methadone is a substitute for heroin. It's usually given to help people kind of wean off of heroin without going into a full-on withdrawal. It affects the mu opioid receptor. And in 40 post-mortem cases, it was found that people with high methadone levels were poor metabolizers and they had slow metabolism. So in this case, instead of them taking a normal level of the drug and having it build up really quick, these people were taking this drug over a prolonged period of time and they weren't metabolizing it well. So it was just kind of sitting in their system and building up that way. So it doesn't say when I was looking up about this case if the 40 cases were necessarily due to methadone overdoses, but it's definitely possible. And again, this has to do with kind of therapeutic drug monitoring, which we're going to talk about more in a little bit. But the importance of knowing your genotype or your phenotype for these CYP2D6 genes can really help make sure that people are taking drugs in the amount that they should be. And then this next kind of little case study I think is really interesting. So this is mirtazapine. So this is mirtazapine, and it is a tetracyclic antidepressant exhibiting anticholinergic adverse effects. So I don't know if any of you remember from chemistry, but there's enantiomers of drugs of kind of molecules in general, and that's when they have different stereochemistries. So you can see here that the R mirtazapine has that H on a wedge, and the S mirtazapine has an H on the slashed lines. So people who have the normal CYP2D6 genotypes, and they're considered extensive metabolizers in their phenotypes, when they're giving the S enantiomer, it's found to be officially hydroxylated and it kind of works just as it should. And in these people, the R mirtazapine enantiomer produces a more pronounced effect on the heart and blood pressure. But people with ultra rapid metabolizing phenotypes need higher doses of S enantiomers to achieve the appropriate antidepressant sedative effects. But if they do not have ultra rapid elimination of the R enantiomer, it can result in serious adverse cardiovascular effects. So I just think this is really interesting because it's essentially the same drug. It's just the enantiomers that are different, and they have such wildly different effects on the body because of this ultra rapid metabolizer and the need to really quickly eliminate all of that stuff. So I think that this is just a really cool kind of chemistry, toxicology, genetics interface. And then the last drug that I'm going to talk about is clopidogrel. It is an inactive drug, so it's a prodrug that is metabolized to an active metabolite, and this inhibits platelet aggregation, so it helps with clotting. And in this case, this is the CYP2C19 gene, and ultra-rapid metabolizer will have an improved protective effect of clopidogrel treatment after a heart attack, which will then increase their risk of bleeding. So clopidogrel is given to people who just had heart attacks or are recovering from surgery to decrease the risk of blood clots. And so kind of what we were thinking about before, if you're given a prodrug and you're an ultra rapid metabolizer, you're going to produce a lot more of that active metabolite. So in this case, if a person who is an ultra rapid metabolizer is given a normal dose of clopidogrel, their blood's going to become really thin. So it is good because it will help prevent a blood clot, but it is not good because it will increase the risk of bleeding. And then on the other hand, poor metabolizers have reduced effectiveness of clopidogrel, so they're at an increased risk for blood clots. So all of this kind of brings us to what I'm actually doing my thesis research on. So I just wanted to talk to you about that a little bit. So I'm looking at therapeutic drug monitoring and CYP2D6 polymorphisms. So I talked about therapeutic drug monitoring a little bit so far, but I just wanted to explain what it is. So it is a system that's often used to ensure that prescribed medications are being used in accordance to the prescription to try and detect non-adherence or abuse. And while this is useful in determining the patients that are properly taking their medication, it can also have consequences for people who are found to be non-adherent or negligent. So the best types of therapeutic drug monitoring test for a steady state range compared to just whether the drug is positive in the sample or not. Steady state drug tests work on the principle that if you are taking a certain amount of drug over a course of time at regimented intervals, then you should always have a certain amount of that drug or its metabolite in your body system at any given time. So a lot of people will try to adulterate their therapeutic drug monitoring if they are not taking their prescription in accordance. So if you know that you're getting, let's say, a urine test, and that test is just going to test, is there drug in my system or not, somebody could potentially be selling their prescribed medication, and they know they have to go take this drug test. They'll take their dose right before they go in, a half hour before they go in. They'll give the urine sample, and it'll come back positive for the drug. And that's great. It was supposed to come back positive. With therapeutic drug monitoring, if they're supposed to have a certain amount of drug in their system, which is calculated through this calculation, and it's known ahead of time, and you're assuming that they're not taking this drug test right after they take the medication, and you're able to figure out what the steady state range should be, then you're able to say, like, hey, this person took this medication right before, they either need to be retested or like something needs to happen because they're not taking this prescription in accordance with how they should. And my research is based on the idea that some out of range results detected by therapeutic drug monitoring may be false due to CYP polymorphisms that are causing the individual to fall out of range. Specifically, I'm going to be looking at the CYP2D6 polymorphism in individuals who are out of range on oral fluid steady state drug tests. So kind of a lot, but I'm going to be working with Dr. Stripp's lab because they created this oral fluid drug test for the steady state range. So what we want to look at is they've had thousands of people with take this drug test, and some of them are perfect, they're in range, some of them are out of range, they're too high, some of them are out of range because they're too low. And every once in a while, you'll have people who are like, I swear I'm taking this drug as I should. I don't know why this is happening. And there can be some pretty strict consequences for people who are found to be abusing therapeutic drug monitoring. So we're hopeful that the results of this study will validate the oral fluid drug testing program and aid in the explanation for some out of range tests, and also bring importance to the role of pharmacogenetics in forensic toxicology. So before I let you guys go, I do have some homework assignments for you. Hopefully they're not too bad. But for one of them, just define phase one and phase two metabolism. You can give some examples of maybe the um, what's going on chemistry wise, what functional groups are being added onto the drugs, and then find a drug of your choosing aside from codeine and heroin, because those are the ones that I went over, and make a flow chart, kind of like what I made a few slides ago, and note if there's active metabolites in the metabolism, and note where phase one metabolism takes place, where phase two metabolism takes place, and if you can find what enzymes are there. You don't have to, if it's kind of complicated like codeine was, you can just put it in a couple of places just to kind of get the gist, like, oh, CYP2D6 is a phase one metabolism. And then in your own words, explain either why or why not you think the role of pharmacogenetics should be explored in the world of forensic science. And then if you guys have any questions, either about grad school, thesis research, anything that I talked about today, here's my email address, and you can just reach me anytime. I'll respond as pretty much as soon as I see it. So yeah, I hope you have a great rest of your day, and thanks for watching.